Welcome back to the deep dive. Today we are really getting into something fundamental, a high-stakes immersion, if you will, that's custom designed for the MD anesthesia candidate.
That's right.
We are tackling local anesthetics and probably the single most critical emergency they can cause. Local anesthetics, systemic toxicity, LS.
And this really isn't just theory for the sake of theory. This material, from the molecular kinetics that dictate how fast a drug works, right up to the exact algorithm you have to run in a crisis, it's the absolute foundation of regional anesthesia safety.
So our mission today is mastery.
Total mastery. We want to give you that analytical depth that, separates just a factual answer from a really high-scoring mechanistic explanation in your board exams. We're going to deconstruct this layer by layer.
Okay, let's start with those fundamentals then. Before we even talk about specific drugs, let's define what local anesthesia actually is. How does it achieve this temporary silence in the nervous system?
Right. So at its core, a local anesthetic compound, or LA, is something that creates a temporary, and this is the key, a completely reversible blockade.
A blockade of what exactly?
Of impulse conduction.
Right.
Right there in the nerve fiber where you apply it. So you get that loss of sensation and potentially motor function too, but this is the entire point. Without impairing consciousness, it's a very controlled chemical interruption.
And that interruption, it all comes down to the mechanism of action at the sodium channel. I feel like if you understand this part, this sort of molecular dance, the whole clinical picture just falls into place.
You're absolutely right. The voltage-gated sodium channel is the target. It's the bullseye.
Okay.
The whole goal is to prevent that rapid inward flow of sodium ions. The current, that's absolutely essential for depolarization and for an action potential to actually propagate down the nerve.
So how does the LA molecule actually do that? What's its journey?
Well, the LA molecule is a weak base, and it has to navigate two very different chemical environments. The space outside the neuron and the space inside it.
And the first hurdle is that cell membrane.
Exactly. The neuronal lipid membrane. It's highly lipophilic. So the LA molecule has to cross this barrier, and it does that primarily in its unionized lipid-soluble form. We often just call it B.
The base form.
The base form, yes. But once it gets inside the axoplasm, the pH is a bit more acidic than the outside. This change makes the unionized base re-equilibrate. It gets protonated and converts into the ionized cationic form, BH plus B.
So a critical two-step process. The neutral base, B, gets it through the door, but it's the charged cation, BH plus B, that actually does the work.
That is the perfect way to put it. And that cation, the BH plant A, is the primary active species. It has to access a very specific receptor site deep inside the pore of the sodium channel.
And where is that site?
It's often called Site 9, part of the S6 segment of Domain 4. And by binding there, it just physically obstructs the channel. It's like putting a plug in a drain. Sodium can't get through.
That distinction, penetration versus action, I can already hear the Viva question. But here's where it gets really elegant. And it's a cornerstone concept. The modulated receptor hypothesis. Why don't these drugs bind to all channels equally?
This is a beautiful concept. It explains the efficiency and the selectivity of the block. The hypothesis states that LA agents have a vastly higher affinity for sodium channels that are already in the open or the inactivated states.
The states they're in when the nerve is firing.
Precisely, compared to when they're in the resting state. If a nerve is silent, most of the channels are resting and binding is slow. But if a nerve is actively firing, sending pain signals, the channels are flipping constantly between open and inactivated states, and that just massively facilitates the drug binding.
And this leads directly into another core concept, which is use-dependent blockade.
Exactly. Use-dependent block, or you might hear it called frequency-dependent blockade. It just means that repeated depolarizations, a high frequency of nerve firing, increases the cumulative time the channels spend in those high-affinity states.
So the more a nerve fires, the more blocked it gets.
That's it. So with each successive action potential, a larger fraction channels gets bound by the LA. In clinical terms, actively firing pain nerves get selectively and rapidly blocked, while less active motor nerves are spared or blocked much later. It's an incredibly desirable selective action.
Okay, so let's zoom out from the molecular level. The result of a successful block is something we see clinically. Differential blockade. We don't lose all function at once. What dictates that order of loss?
Right. Differential blockade is all about nerve fiber size and myelination. The general rule, and you absolutely need to know this for your exams, is that small myelinated fibers are blocked much more easily than large unmyelinated ones.
So things like A-delta fibers for pain and temperature.
Exactly. They go first. They require a lower La concentration. Then you have the large, heavily myelinated motor fibers, the A-alpha fibers, which are the most resistant.
And this creates that classic clinical order of loss.
It does. First, you get sympathetic blockade. You'll see the skin warm up. And this often extends a couple of segments higher than the sensory block. Second is the sensory block itself, loss of pain, then touch. And third, requiring the highest concentration and the most time, is the motor block.
Which allows us to do things like provide pain relief during labor without stopping the patient from being able to push.
That's a perfect clinical example. It's all about exploiting that differential effect.
Okay, so now let's transition from the how to the what. Let's talk about the molecules themselves. Structure defines function, and with LAs, that's absolutely the case.
It really is. Every single clinically useful LA shares 3 parts: a lipophilic aromatic ring, a hydrophilic amine, and an intermediate chain. And it's the chemical linkage in that intermediate chain that defines the entire class.
Let's start with the older class, the ester group. What's their defining link?
The esters have an OQO link. The classics here are drugs like cocaine, procaine, Novocaine, chloroprocaine, and tetracaine.
And what's the clinical consequence of that ester link?
Instability. Esters are pretty unstable in solution, and this instability directly affects their metabolism and their allergy profile.
How so?
Well, esters are broken down incredibly rapidly right in the plasma by pseudocholinesterase enzymes, so they have a very, very short plasma half-life. But the key thing is the metabolite they produce. PAGA, or p-aminobenzoic acid. This PABA metabolite is a known antigen, and it's strongly associated with the much higher incidence of true allergic reactions we see with the ester class of drugs.
Okay, so now let's contrast that with the amide group, which is really the backbone of modern regional anesthesia.
The amides have an NHCO link, and this list is crucial. Lidocaine or Lidocaine, Bupivacaine, Ropivacaine, Bupivacaine, Mepivacaine, and Lidocaine.
And that amide bond gives them stability.
High stability. You can autoclave them. They're stable in solution for ages. But it also means their metabolism is a much slower, more complex process.
Not in the plasma, then.
No, amides are metabolized slowly and primarily in the liver by the microsomal P450 enzyme system. And because this is slow and depends on things like liver blood flow and enzyme function, the risk of accumulation is higher.
And what about allergies with amides?
True allergic reactions are exceedingly rare. I mean, vanishingly rare. When a patient says they have an amide allergy, it's almost always a reaction to a preservative, like methylparaben, which, funnily enough, is structurally similar to PABA and metabolizes to it.
Fascinating. Okay, let's move on to another way we classify these drugs, which is just based on how long they work, their duration of action.
Right. This is the practical clinical classification. We have short-acting agents like procaine and chloroprocaine because they're cleared so fast.
Then the workhorses.
The intermediate-acting ones, yes. That's your
Yeah.
Lidocaine, Lidocaine, Mepivacaine, and then the long-acting drugs. Tetracaine, Bupivacaine, Ropivacaine, and Levobupivacaine, which are defined by their high lipid solubility and high protein binding.
Lastly, under classification, let's touch on vasodilatory properties. Most of them cause vasodilation, which is not what you want.
Right. It washes the drug away from the nerve, reducing the duration and potency. It's why we often add a vasoconstrictor like epinephrine. But there is one infamous, always on the exam exception.
Cocaine?
Cocaine. It's the only LA that produces vasoconstriction at all concentrations, and it does this because it blocks the reuptake of norepinephrine at the nerve terminals, which potentiates the local sympathetic activity.
Okay, that's a fantastic foundation. Now let's dig even deeper into those physicochemical properties that really drive the clinical effects. pKa, lipid solubility, and protein binding. Let's start with pKa and onset of action.
Okay, so the pK is the pH at which half the drug molecules are ionized, the charged BH plus form, and half are unionized, the neutral base B form. All our LAs are weak bases, with pKa values mostly above physiological pH of 7.4.
And we already established that the unionized form B is the one that gets through the nerve membrane.
Exactly. So we can establish a pretty solid general rule from that. The closer the drug's pK is to the body's pH of 7.4, the higher the percentage of that unionized base form is available to penetrate the nerve.
So lower pKa means faster onset.
Lower pKa, faster onset. It's a great rule of thumb. Lidocaine with a pKa of 7.9 is generally faster than Bupivacaine, which has a pKa of 8.1.
But every good rule has an exception, and the examiners love this one. The massive clinical exception, the Viva trap. Chloroprocaine.
Ah, yes. Chloroprocaine, its pKa is 9.1, the highest of the common agents. So by the rule, it should be incredibly slow. But clinically, it's one of the fastest.
How do we explain that?
It's all about concentration. The pKa rule holds true when you compare drugs at equivalent concentrations. But chloroprocaine has such a low toxicity profile that we can use it in very high concentrations, like 3%. So you're putting such a huge mass of drug there that it creates this tremendous, overwhelming concentration gradient across the nerve sheath. That gradient just forces the drug across, completely overriding the unfavorable ionization. It's concentration gradient versus pK-dependent fraction, a critical distinction.
Excellent. Next, lipid solubility and potency. What's the relationship there?
It's almost a straight line. Potency is directly correlated with lipid solubility. Higher lipid solubility means easier diffusion through the membrane and, crucially, a higher affinity for that hydrophobic binding site inside the sodium channel.
And you can see this in the chemistry.
Absolutely. If you take mepivacaine and add a butyl group to make bupivacaine, you massively increase the lipid solubility.
Yeah.
You know, if you look at the partition coefficient, lidocaine is about 43, while bupivacaine is around 346. That's why bupivacaine is 4 to 8 times more potent.
Okay, and the third driver, protein binding and duration of action.
The duration of action is directly proportional to how much the drug binds to protein. We're talking mainly about plasma proteins, especially alpha-1 acid glycoprotein, or AGP, and also albumin.
And AGP is the key one here.
It's the key one. When the LA is highly bound, it's essentially held in reserve at the site of action. It's like a local reservoir that slowly releases the drug. Only the unbound free fraction can diffuse away or be cleared.
So more binding equals a longer-lasting block.
Precisely. Bupivacaine is about 95% protein bound, which is why it lasts so long. Compare that to procaine, which is only 6% bound and wears off very quickly.
This all leads to a really important clinical scenario.
Yeah.
Injecting into infected or inflamed tissue, the block often fails. Why?
Because of the pH. In inflamed or infected tissue, the local environment is acidic. The pH can drop to 6.5 or even lower. And if you remember your Henderson-Hasselbalch equation, this low pH dramatically shifts the equilibrium towards the ionized cationic BH+ form.
The form that can't cross the membrane.
The form that's stuck outside. So the fraction of the necessary penetrating base form, B, just plummets. We call this local ion trapping at the injection site. It basically antagonizes the block, which is why you must manage local infection before you even attempt regional anesthesia.
A fundamental clinical point.
Yeah.
Okay, let's follow the journey of the drug once it's injected. The pharmacokinetics. The first step, absorption, is probably the most important factor for toxicity risk.
Without a doubt. The systemic absorption rate is dictated entirely by the vascularity of the injection site. And this risk ranking is something you just have to commit to memory.
Let's go through it. Highest absorption and risk to lowest.
Okay, from highest to lowest, the order is intravenous, which is a direct toxic bolus, then tracheal or intercostal.
An intercostal is a big one to remember.
The huge one. It's incredibly vascular. So IV tracheal, intercostal, then paracervical, then epidural, then brachial plexus, then sciatic or femoral, and finally the lowest risk is subcutaneous. The difference in risk between an intercostal block and a femoral block is massive.
Which is why we add vasoconstrictors like epinephrine. How do they help?
Epinephrine causes local vasoconstriction, which does two crucial things. It keeps the LA at the nerve site longer, so it prolongs the duration of the block. And just as importantly, it reduces the peak plasma concentration by slowing down systemic absorption.
So it makes the block better and safer.
Exactly. For a drug like lidocaine, it can reduce the peak plasma concentration by about 1/3, which significantly increases the maximum safe dose you can give. But a quick clinical pearl.
Go on.
Epinephrine is much less effective at prolonging the duration of the highly lipid-soluble, long-acting drugs like bupivacaine. They're already so highly tissue-bound that their local clearance is slow anyway.
Good point. So once absorbed, the drug enters the distribution phase. Where does it go first?
It follows perfusion. So the initial rapid distribution phase sends the LA to the highly perfused organs: brain, heart, liver, lungs, and kidneys.
And one of those organs acts as a critical protective buffer, right?
Yes, the lungs. The lungs are a vital reservoir. They can extract a huge amount of LA during that initial first pass through the pulmonary circulation. This acts as a buffer, scavenging the drug before it gets to the systemic arterial side and hits the brain and the heart.
So any condition that bypasses that buffer is a major red flag for toxicity.
A huge red flag. A patient with a right-to-left cardiac shunt, for example. The LA bypasses the lung entirely. That means you get much higher arterial concentrations and a drastically increased risk of CNS and cardiac toxicity for the same dose.
Okay, now for metabolism. This is where that structural difference between esters and amides really comes into play. Let's quickly recap the esters.
Ester metabolism is simple and fast. They're hydrolyzed in the plasma by pseudocholinesterase. The main clinical point here is for patients who have a deficiency of that enzyme. It can prolong the effect, but it's usually less of a concern than with the amides.
And the amides, the more complex pathway.
Right. Amide metabolism happens in the liver. It's a two-step process of N-dealkylation and hydroxylation by the microsomal P450 enzyme system, mainly CYP1A2 and CYP3A4.
And the rate of that process is what determines the toxicity risk.
Exactly. And there's a clear order to how fast they're metabolized. Lidocaine is the fastest, then Lidocaine, Bupivacaine, Ropivacaine, and the slowest of all is Bupivacaine.
Which explains why Bupivacaine has the highest risk of accumulating, say, in a continuous infusion or in a patient with a sick liver.
Precisely. Any drug that inhibits those P450 enzymes or any condition that reduces liver blood flow is going to slow down clearance and increase your risk.
And finally, excretion.
The water-soluble metabolites from both groups are just excreted by the kidney. Renal failure doesn't really affect the clearance of the parent amide drugs much, but it can lead to an accumulation of some other active metabolites, which can contribute to CNS toxicity.
Okay, so that's the journey. Now for the destination, the pharmacodynamics, and the systemic effects when things go wrong. CNS versus CVS, which system is more sensitive?
The central nervous system. The CNS is generally more susceptible. The plasma concentration you need to see CNS effects, like seizures, is typically lower than what you need for a full-blown cardiovascular collapse.
Although with Bupivacaine, those thresholds are dangerously close.
Perilously close, yes.
Let's revisit that CNS mechanism. Why do we see excitation first before the depression sets in?
It's a paradox, isn't it? The initial excitatory phase, the tremors, the seizures, happens because the LA selectively blocks the small inhibitory interneurons first. Think of them as the brakes in the brain.
So you're blocking the brakes.
You're blocking the brakes. Specifically, the GABAergic pathways in the amygdala and the cortex. This allows the larger, less sensitive facilitatory neurons, the accelerators, to fire unopposed. That's your excitation.
Wow.
Only at higher doses do you block the accelerators too, and then you get generalized CNS depression, coma, and respiratory arrest.
Now for the heart, the cardiovascular system.
Yeah.
LAs at toxic doses are basically class I antiarrhythmics gone rogue.
That's a good way to put it. They cause a direct membrane stabilizing action. They block sodium channels in the cardiac conduction system, which leads to dose-dependent negative inotropism, a weaker pump bradycardia, and conduction delays. You'll see a prolonged PR interval and a widened QRS on the ECG.
And at very high concentrations.
At very high concentrations, they also block potassium and calcium channels, which makes everything worse. You get severe hypotension from vasodilation and ultimately refractory ventricular arrhythmias.
This brings us to the single most important metric for comparing the safety of these drugs, the cardiovascular collapse to CNS ratio, or CC-CNS ratio. This is what makes Bupivacaine so feared.
It is. The CC-CNS ratio tells you how much warning you get. For Lidocaine, the ratio is pretty high, around 7. This means you get significant CNS warning signs like a seizure well before the heart is in serious trouble.
But for Bupivacaine,
the ratio for Bupivacaine is dangerously low, maybe as low as 1.5. This means cardiotoxicity can happen incredibly fast, often with no warning at all. The first sign of trouble can be a sudden, profound, and incredibly difficult to treat cardiac arrest.
And briefly, any effects on skeletal muscle?
Yes, LAs can be directly myotoxic if you inject a high concentration into muscle, but it's usually transient. Systemically, the effects are minor compared to what's happening in the brain and heart.
We mentioned this before, but it's so important we have to hammer it home. The amplifying factors. Why do hypoxemia and acidosis make a last so much worse?
This is a guaranteed exam question. It's about clinical physiology. Acidosis and hypercapnia, high CO2, dramatically worsen both CNS and CVS toxicity. Hypercapnia increases cerebral blood flow, so you deliver more drug to the brain faster.
But the real key is what happens inside the cell.
The real key is ion trapping. Intracellular acidosis from either hypoxia or hypercapnia forces the conversion of the unionized base B back to the active cationic form BH+ inside the cell.
And that charged form can't get back out.
It's trapped. So you dramatically increase the effective concentration of the active drug right at the sodium channel receptor. This lowers the seizure threshold, intensifies myocardial depression, and makes resuscitation a nightmare. This is why 100% oxygen and controlled ventilation are the absolute first line of defense.
A crucial point. So now let's layer in the patient-specific factors that can modify all of this. Dose and concentration are obvious.
Right. More drug equals more block, but also more risk. That's straightforward.
And injection site we've covered. The intercostal danger zone.
Yes. Always be mindful of that absorption ranking.
So let's focus on the patient themselves. Age.
Extremes of age are a big deal. Infants and neonates have very low levels of that key binding protein, alpha-1 acid glycoprotein. This means for any given dose, a much higher fraction of the drug is free and active in the plasma.
So they're at much higher risk.
Much higher. And to make it worse, they often don't show those classic early warning signs. They might just go straight to a seizure. Elderly patients, on the other hand, have slower Amides metabolism and often need less drug for neuraxial blocks.
What about pregnancy? How does that change things?
Pregnant patients need about 30% less LA for the same epidural spread. It's mostly a mechanical thing. The gravid uterus causes epidural vein engorgement, which shrinks the epidural space and forces the drug to spread further. There's also some evidence that the pregnant cardiovascular system is slightly more susceptible to cardiotoxicity.
And organ dysfunction. A patient with a bad liver or a bad heart.
That's a huge risk factor for Amides. Liver disease, like cirrhosis, just kills your P450 enzyme activity. And low cardiac output, like in congestive heart failure, reduces blood flow to the liver, so the drug isn't delivered for metabolism. In both cases, the half-life shoots up, and the risk of accumulation, especially with an infusion, is massive.
Finally, drug interactions. What other drugs can make things better or worse?
Well, drugs that raise the seizure threshold are protective. So IV benzodiazepines, or cautiously propofol, they enhance GABA inhibition, which counteracts what the LA is doing. And on the other side, as we said, acidosis and hypercapnia dramatically lower the seizure threshold.
Okay, let's briefly run through the clinical applications, the different ways we use these drugs.
Right, we can think of it in about 6 main areas. You've got the most superficial, topical anesthesia, like a cream, and then infiltration and field block, which are pretty low risk.
Well, we move to the more advanced techniques.
Exactly. Peripheral nerve blocks, or PNBs, which are now almost all done under ultrasound guidance. We've moved away from big fixed volumes towards using just enough to cover the nerve.
And then neuraxial.
Right. Spinal anesthesia uses tiny volumes of high concentration drug right into the CSF. Here, spread is all about baricity, the density of the solution, and patient positioning. Epidural anesthesia uses much larger volumes, and it's the total mass of drug that determines the height of the block.
And lastly, the slightly more niche one, 5E regional anesthesia.
Beer's block, yeah. Here you're filling an exsanguinated limb with a large volume of low-concentration LA. The risk isn't absorption, it's a catastrophic systemic bolus if that tourniquet fails or is let down too early. You have to respect the minimum tourniquet time.
Okay, that brings us to the absolute core of this deep dive. EST. This requires total clarity. Definition and epidemiology first.
EST is defined as the clinical signs and symptoms you get from a high plasma concentration of local anesthetic. It's usually from an accidental rapid intravascular injection, but can also happen from absorbing too much over time.
And how common is it?
The incidence is low, but the outcome can be devastating. It's maybe 1 in 1,000 for older techniques, but that drops to about 1 in 1,600 or even lower for blocks done with real-time ultrasound. That really shows you the protective effect of being able to see where your needle tip is.
Let's really drill down on the pathophysiology again, especially for the heart. We know lidocaine is safer than bupivacaine. Why? What's happening at the cellular level?
It's all about the kinetics of the block. Lidocaine binds and dissociates from the cardiac sodium channel relatively quickly. During diastole, when the heart is relaxing, the lidocaine comes off and the channel is ready for the next beat.
But bupivacaine is different.
Bupivacaine is the cellular red flag. It's highly lipid-soluble, so it gets into the channel easily. But critically, it has an extremely slow dissociation rate. It doesn't want to let go during diastole.
So the block is cumulative.
It's cumulative. With every single heartbeat, fewer and fewer channels are available. This leads to profound conduction defects that widened QRS and eventually these incredibly resistant ventricular arrhythmias. And there's more.
In energy metabolism.
The energy metabolism. Bupivacaine also inhibits a key enzyme that transports fatty acids into the mitochondria. The heart loves to burn fatty acids for energy, so you're not just blocking its electrical system, you're also starving it of its primary fuel source, which makes it incredibly difficult to resuscitate.
Okay, let's walk through the clinical features, the signs. We teach a sequence, but we have to stress it's unreliable.
Absolutely. About 40% of cases skip the classic early CNS signs and go straight to cardiovascular collapse. But when you do see them, the early signs are subjective.
The patient have to be awake to tell you.
Right. You're looking for circumoral paresthesia, that classic tingling around the mouth and tongue, a metallic taste, lightheadedness, tinnitus, maybe some visual disturbances,
And then it progresses to the late CNS signs.
which are objective motor symptoms: shivering, muscle twitching, tremors, and then full-blown tonic-clonic seizures, followed by deep CNS depression and respiratory arrest.
And the dreaded cardiovascular signs.
At the highest concentrations, you'll see bradycardia, severe conduction defects, then ventricular arrhythmias, severe hypotension, and finally a resistant VT or VF, or a systole.
Diagnosis is all about timing and clinical suspicion.
It's a clinical diagnosis. It's all about the temporal relationship. Did these things happen within seconds or minutes of an LA injection? That's your diagnosis. And you have to quickly rule out other mimics like hypoxia, an allergic reaction, or an accidental total spinal.
Which brings us to prevention. This is our highest priority. Let's run through the safety protocol, starting with dose calculation.
You have to know the maximum dose guidelines. Lidocaine, 7 milligene kilograms, with Bupivacaine around 2 milligene kilograms. But you have to see them as a guide, not a license. You always have to factor in the vascularity of the site.
And the next two steps are just non-negotiable.
Aspiration and incremental injection, absolutely. You inject in small fractions, 3 to 5 milliliters at a time, and you aspirate before every single injection. The mantra is, every dose is a test dose.
Let's talk about that test dose, specifically for epidurals. What's in it, and what are you looking for?
A standard test dose is 3 milliliters of a solution containing two things: a fast-acting LA, like 1.5% lidocaine, and a small amount of epinephrine, usually 15 micrograms.
Two different indicators for two different misplaced needles.
Exactly. If you're in the CSF, the lidocaine will cause a rapid spinal block. If you're in a blood vessel, the epinephrine is your canary in the coal mine. You'll see a jump in heart rate of 20 beats per minute or more within 30 to 60 seconds. That's a positive test.
And of course, the modern tool for prevention.
Ultrasound guidance. It's the gold standard for most PNBs now. It lets you see the needle, the nerve, and the local anesthetic spreading. The evidence is clear that it reduces the incidence of AST.
And finally, constant, vigilant patient monitoring.
Absolutely. But remember, part of that monitoring is managing their physiology. Keeping them normocapnic and well oxygenated isn't just good care. It's an active preventative measure against toxicity.
Okay, this is it. The section that needs to be automatic. The management of LAST. Let's walk through the immediate crisis checklist.
As soon as you suspect it, you move. Number 1, stop injecting the local anesthetic immediately.
Obvious but critical.
2, call for help. Activate your AST protocol, call a code blue, get more hands. 3, airway and oxygenation. Get them on 100% oxygen and secure that airway. You must prevent hypoxia and control CO2 to prevent that ion trapping. This usually means intubation.
4, seizure management.
Control the seizure immediately to stop the brain damage and worsening acidosis. First line is IV benzodiazepines, midazolam, diazepam. You can use propofol, but be very, very careful. The patient is hemodynamically unstable. Its cardiac depressant effects can push them over the edge.
And 5, circulation.
Right. 5E fluids, vasopressors, and immediate high-quality CPR if there's any sign of cardiac arrest.
The moment you suspect cardiovascular collapse, the game changer has to come out. Lipid emulsion therapy. Why does it work?
It's the lipid sink theory. You're injecting a 20% lipid emulsion, which creates this big, fatty, lipophilic phase in the blood. The highly lipid-soluble LA molecules, especially bupivacaine, are basically sucked out of the plasma and away from the heart and brain receptors.
It's like a chemical sponge.
It's a chemical sponge. It scavenges the drug. There's also some thought that it provides a direct energy source to the starving myocardium.
Let's detail the dosage protocol. This is something you have to know by heart.
You absolutely do. For 20% lipid emulsion, 1, an initial bolus of 1.5 milliliter per kilogram given rapidly over 1 minute.
Bolus first.
Bolus first. Then 2, immediately start a continuous infusion at 0.25 milliliter per kilogram per minute.
And if they're still unstable?
3, you can repeat that 1.5 milliliter per kilogram bolus up to 2 more times every 5 minutes. And you can double the infusion rate to 0.5 milliliter per kilogram per minute if you need to.
Is there a maximum dose?
There is. You continue until a patient is stable, but the total recommended max dose is generally around 10 milliliter per kilogram over the first 30 minutes.
Okay, finally we have to talk about the critical modifications to the standard ACLS algorithm. For last arrest, some standard drugs are dangerous.
This is a major exam point. You must avoid, or at the very least strictly limit, vasopressin, calcium channel blockers, and beta blockers. They will all make the LA-induced myocardial depression and conduction blocks worse.
What about epinephrine?
If you need to use epinephrine for asystole or PEA, use small incremental doses, less than 1 microgram per kilogram at a time. Large doses of epi can actually worsen cardiac dysfunction after you get them back.
And what about the CPR itself?
You have to be prepared for prolonged CPR. An LA-induced arrest often requires a much longer resuscitation time, 30 minutes or more, while the lipid does its work. And if you're not getting anywhere, you have to think about getting them on cardiopulmonary bypass or ECMO early.
A huge amount to remember in a crisis. Let's quickly touch on a few special situations. Asked in pregnancy.
It's rare because we use low concentrations for labor analgesia, but remember the physiology changes, and any cardiac arrest in pregnancy after 20 weeks requires immediate consideration of a perimortem C-section to improve resuscitation efforts.
Yeah, on ALSD in kids?
We've mentioned the lower protein binding, which increases the free drug. The other key is they don't show the classic warning signs. Any irritability or twitching in a child after a block has to be considered potential toxicity until proven otherwise.
And just to reinforce the risk with specific regional blocks.
It's that ranking again. Intercostal and paracervical carry the highest absorption risk. Always be extra vigilant with those.
Perfect. Now for the synthesis part. Examiners love comparative questions. So let's put Lidocaine versus Bupivacaine side by side.
This is the fundamental safety comparison. Lidocaine is your reference standard. Lower potency, lower lipid solubility, rapid onset, and a high CC-CNS ratio. You get a warning before the crash.
And Bupivacaine
Is the high-risk agent. High potency, high lipid solubility, slower onset, and that dangerously low CC-CNS ratio. Its toxicity is all about that slow dissociation from the cardiac sodium channel.
Next, the safety innovation. Comparing racemic Bupivacaine to ropivacaine or levobupivacaine.
Right. Bupivacaine is a 50-50 mix of two mirror image molecules. Ropivacaine and levobupivacaine are pure single stereoisomer versions. The bottom line is safety. Ropivacaine has significantly lower cardiotoxicity than Bupivacaine, which is why it's preferred for large volume blocks or continuous infusions.
And finally, the clean, concise summary. Ester versus amide.
This is your revision note. Linkage. Ester versus amide. Metabolism. Plasma cholinesterase versus hepatic P450. Allergy risk. High with esters because of CABA versus very low with amides. And duration. Generally shorter for esters, longer for amides.
Okay, we've covered a huge amount. Let's finish by focusing on exactly what the examiners are going to target. What are the big ticket items for long questions?
You need to be able to write detailed essays on 3 things. 1, the complete mechanism of action, including the modulated receptor hypothesis. 2, the pharmacokinetics and factors affecting amide toxicity. And 3, the complete step-by-step management of LAST with the lipid algorithm and the ACLS modifications.
And for the Viva, those quick one-liners that show you really know your stuff.
You need to be able to state instantly. The penetrating form is the unionized base. The active form is the ionized conjugation. The most hazardous site is intercostal. The reason Bupivacaine is so dangerous is its slow dissociation from the cardiac sodium channel.
And the Viva traps. The questions that seem simple but trip people up.
They'll ask why the CNS gets excited, and you have to say it's because of the blockade of inhibitory pathways. They'll ask about the chloroprocaine exception, and your answer is the high concentration gradient. And they'll ask about acidosis, where you must use the term ion trapping.
So to wrap this all up, what are the 3 visual aids you should have on a rapid revision sheet?
Number 1, a LAST management flowchart. Step by step with the lipid doses bolus 1.5 millivector per kilogram, infusion 0.25 millimole per kilogram per minute. Number 2, the LA absorption ranking table. And number 3, a maximum dose reference table, which you use as a safety framework.
Fantastic. That brings us to the end of a very deep dive, one that should really be a cornerstone of your preparation. We've gone from the molecule to the emergency room.
And remember, mastering this isn't just about passing an exam. It's the absolute measure of your commitment to patient safety. The real frontier isn't just knowing how to treat toxicity, but understanding the subtle differences between these drugs and using technology like ultrasound to make sure it remains a rare event.
Prevention through knowledge is always better than resuscitation. Absolutely. Go back to your sources, structure this information, and get ready to explain the why behind every fact. Until our next deep dive, be well informed and confident in your practice.